Thank you all for joining us this afternoon. We're excited to have today with us Dr. Sheldon Campbell from Yale School of Medicine to be presenting on influenza diagnostics. Just a couple housekeeping tips ahead of time. In the lower left corner of your screen, you should notice a CE button, and then below that is a green Q&A button. If you have any questions that you'd like Dr. Campbell to answer during the presentation or afterwards, please go ahead and type them in by pressing the green Q&A button now, and then you can enter your questions and we'll answer them during the Q&A. At the end of the presentation, you can click the CE button in the lower left corner in order to be taken to the page to get your CE credits. And this webinar is approved for 1 PACE credit, or if you're in Florida, for the Florida credits. And for anyone who's attending, just everybody go ahead and click on that and fill out the form and you'll get your CE credits. Dr. Sheldon Campbell is Associate Professor of Laboratory Medicine at Yale School of Medicine, and he's the Director of Clinical Laboratories for the VA Connecticut Healthcare System. He obtained his bachelor's degree in biology from Rice University in Houston, Texas, and completed both his MD and PhD degrees in the Medical Scientist Training Program at Baylor College of Medicine, which is also in Houston. He was a resident and postdoc fellow in the laboratory medicine at the Yale School of Medicine and is board certified in clinical pathology and medical microbiology. Dr. Campbell is Director of Clinical Laboratories and Medical Director for Chemistry, Microbiology, Mycobacteriology, and point-of-care testing for VA Connecticut. And he also has a role in microbiology and chemistry specialty areas for the New England Veterans Integrated Service Network Laboratories. Dr. Campbell is the director of the Yale Medical School Medical Microbiology and Infectious Diseases course and Yale Winchester Medical Microbiology Fellowship Program. Dr. Campbell's research interests include education of pathology residents and medical students, point-of-care testing, HIV testing, and cost-effective clinical microbiology practice. So once again, if you have questions, please remember to enter them into the green Q&A box in the lower left corner. And with that, I'll hand it over to Dr. Campbell.
Thank you. I think this is probably a timely topic. It's almost flu season, and everyone's embroiled in Ebola, but we're going to have to distinguish rule out Ebolas from flu, and so you can count this as part of your Ebola preparedness activities. I'm going to talk about flu diagnostics in 2014, and this is such a rapidly changing area that who knows if it'll be any good in 2015. Ooh, okay. So the topics I'm going to cover are what is influenza, and how can you protect yourself and your family. And then the bulk of the talk will be on testing for influenza, methods, rapid tests, and focusing on molecular methods, hopefully for almost everyone. The word flu gets tossed around a lot. People say they had the stomach flu, but it's not the stomach flu, right? That was probably norovirus or a bad oyster. Influenza is a primarily respiratory disease caused by the influenza virus. There are influenza A and B viruses. A is more common, but both cause seasonal flu, and both are serious illnesses. In the United States, somewhere between 5 and 20% of the population gets flu every year. More in pandemic years like 2009, less in some years. It goes up and down in ways that we don't necessarily understand all that well. But it results in 200,000 hospitalizations and between 5 and 20,000 deaths each year from influenza. So it's not just the flu. Worldwide, influenza is a disease of tremendous public health importance. 3 to 5 million severe cases and 250 to 500,000 deaths per year from influenza. Symptoms of influenza, and if you're paying attention to Ebola, you'll discover that there are an awful lot of similarities here. Include sudden onset of fever, headache, extreme tiredness, dry cough, sore throat, runny nose, muscle aches, and often gastrointestinal symptoms, nausea, vomiting, and diarrhea, which are more common in children. And we're seeing in up to a quarter of the cases with the 2009 pandemic strain in 2009. So while influenza is primarily a respiratory disease, it certainly has systemic symptoms and even some GI symptoms. Seasonal flu traditionally is most dangerous for the very old, the very young, and persons with severe underlying illness. So this is mortality from flu over the age range, and you can see it's the highest in children under 1 year old, persons over 65. That does change a little bit when we have something like a pandemic. Typically with outbreak strains and novel strains, it's actually young adults who may suffer the most from influenza because of a severe immune inflammatory response to the virus. So there are ways that you can protect yourself, simple precautions and vaccines. We get influenza via the droplet route. These are droplets. They are coughed out or sneezed out by a person with influenza. They float around for just a short period of time, then they land on surfaces. And typically we get influenza by touching a surface with our hands and then touching mouth, nose, or eyes, and the virus gets in through that route. We don't get influenza by kissing pigs, except if it's a really bad date. But for the most part, we get it through this droplet route. So coughing, sneezing, and then touching the droplets on yourself, on another person, or on a droplet without washing your hands. I'm still learning this thing. Forgive me. So, during the flu season, wash your hands often with soap and warm water, especially after you cough or sneeze. Wash for 15 to 20 seconds. That is a surprisingly long time. It's sort of the length of time it takes to sing happy birthday to you twice. The other option is to use alcohol-based hand wipes and gel sanitizers. They are also effective against the flu virus. Other things you can do is to help protecting yourself and protect others, cover your nose and mouth with a tissue when you cough or sneeze, and then throw the tissue away after you use it. Don't carry it around like I often do when I have a cold and forgot to bring enough tissues with me in your pocket. Get rid of those tissues as soon as you use them. Avoid touching your eyes, nose, or mouth. This is a very difficult thing to do. Most of us touch our face several times an hour. If you are sitting there and trying to be conscious of this, you'll discover that a minute from now you'll have forgotten and touched your face. And avoid contact with sick people. This means when somebody is sick and coughing and hacking around you, avoid contact. It also means that if you're sick, avoid contact with well people. So convince your employer that yes, it is a good idea for you to stay home to avoid infecting everyone around you. Keep your kids home from school if there's any way you possibly can. Keep these viruses in their place. So if you're sick, stay home until you've been symptom-free for 24 hours. And if you're sick, limit your contact with other people as much as possible. There are some warning signs of more severe illness associated with influenza. For most of us, it's a disease that we will recover from relatively easily at home. But emergency warning signs that mean you should seek immediate care include difficulty breathing or shortness of breath, pain or pressure in the chest or abdomen, sudden dizziness, confusion, severe or persistent vomiting, and flu-like symptoms that improve but then return with fever and a worse cough. That's often a sign of a bacterial superinfection that can be very severe. Similarly, in children, rapid breathing or trouble breathing, a bluish or gray skin color, not drinking enough fluid, severe or persistent vomiting, not waking up or not interacting, irritability, not wanting to be held, flu-like symptoms that improve but then return with fever and worse cough. If you see any of these in adults or children, that's a time to contact your doc, or if they're very severe, take the patient to the emergency room immediately. So I have a polling question here. We're trying to do this fancy. Do you plan to get your flu vaccine this year? Let me push this out to the audience and give yourself a chance to answer this question. Let's see how good you are. So I'm pushing these results out. About 80% of you plan to get the flu vaccine this year. About 33% don't. The seasonal flu vaccine is very safe. Most reactions to the flu vaccine are local tenderness. There are a few serious reactions. They usually represent allergy to the egg-based vaccine components. That's why we ask everyone before we give them the flu shot if they have an egg allergy. And there is no association with Guillain-Barré syndrome. This has been looked at very carefully over the last decade or so. And patients who get the flu vaccine are no more likely to get Guillain-Barré than people who did not get the vaccine. And they are much less likely to get influenza. They are much less likely to get the flu and serious complications of it. There are two types of vaccines. The flu shot, which is what most of us get. It's a killed virus, so there's no live virus in that flu vaccine at all. There's single dose for most of us, 2 doses recommended for children from 0 to 9 years old, and there's a high dose, a double strength dose for persons greater than 65. There is also a nasal spray for people who don't want to get the flu shot. That is a live viral vaccine. It's an attenuated live viral vaccine, and it is not for persons with underlying disease or family members of those, because it can actually spread a little bit from person to person. It's unlikely to, but we like to be safe. None of the flu vaccines contain any form of adjuvant. There's no thimerosal. There's no substance other than some flu protein in these vaccines. So I urge you to get your flu vaccine and to get your family members and people around you vaccinated. It is the best way to prevent influenza infection. So people say, well, I got the flu vaccine, but I still got the flu. And that may well be true. The flu vaccine is about 70 to 80% effective in preventing influenza. But there's also just a whole swarm of other vaccines that cause similar illnesses. And so it doesn't protect against the other viruses. And that's why even if you are vaccinated, it's important to wash your hands well, stay home if you're sick, and so on. There's lots of information on the CDC's website about flu vaccines and about ways to stay informed. So enough of that. On to flu testing, which is what you're here for. The main methods for testing for influenza are culture, DFA or direct fluorescent antibody testing, rapid antigen tests, and a whole host of new molecular tests for flu. So let's do another poll. Before the pandemic, what were you using for flu testing? Nothing, rapid antigen, culture, DFA, or a molecular test? Give you a minute to answer this poll. I think it's interesting to see how we have evolved over time on our practices in this area. Hardly any area of medicine has changed more in the last decade than has diagnostic virology. Lots of people answering. Give it just another minute because people are still putting their answers in here. And I'll send the results out. About a quarter of you were doing nothing. That was not uncommon back in 2009. What a lot of people weren't doing any testing. Most people were doing, if anything, a rapid antigen test, about 60%. A few sites, about 7.6% doing culture, a few doing DFA, and about 10% in 2009 were using a molecular test for influenza. So to put flu testing in perspective, here's how it gets used. If a person tests positive for influenza with a positive test, what happens is we tend not to start antibacterials because it's the flu. It doesn't need antibacterial therapy. Antivirals may be used. For best outcome, they need to be started within 48 hours of the onset of symptoms. And the treatment is of modest value for influenza. It decreases the duration and severity of illness, lets people go back to work earlier. It's not what you'd call curative, but it is of some value against influenza. Patients who get a positive flu test will be put on droplet precautions if they're admitted to the hospital, and some other tests may be eliminated. The consequences of a false positive test are potentially severe because you might not treat a bacterial pneumonia. You might not even diagnose a bacterial pneumonia. You might not do the proper testing to diagnose a bacterial pneumonia or another serious systemic illness. Speed is helpful in this because we have to start antivirals within 48 hours of onset. But specificity in flu testing is essential. A flu test that is not specific, that gives false positives, is a potentially dangerous test. And so whatever else you think about your flu testing, it has to be specific. Flu A versus flu B discrimination sometimes matters because at least before 2009, our H1N1s were almost universally Tamiflu resistant. That changed with the 2009 pandemic strain, and now it's susceptible again. But we'll probably have resistant strains come along again. With a negative flu test, we will consider giving antibacterial therapy because it's probably something else. We don't start antivirals. We don't do droplet precautions. And we'll do further diagnostic studies to try and establish the etiology of the disease. The consequences of an error here are moderate. We may overtreat with antibacterials. We may miss the opportunity to institute droplet precautions in an inpatient, which can lead to spread of influenza. But we're not going to undertreat a serious illness. So sensitivity, while highly desirable in a flu test, is perhaps not quite as essential as specificity. And so that's kind of why the rapid antigen tests are viable. Flu culture and DFA, I'm not going to spend a lot of time on. They're used primarily in high complexity settings. They require skilled staff. DFA is a relatively rapid test, takes 1 to 2 hours of hands-on and incubation time. The sensitivity from the top centers for a DFA approaches culture, but it is a very demanding technique to do DFA well for respiratory viruses. It requires a fluorescent scope, and it requires staff that are very good both at performing and at interpreting the fluorescent antibody slides. Culture can give you an answer in 24 to 48 hours with the newest methods. The culture is fairly sensitive, but relative to molecular tests, probably is not quite as sensitive. It used to be the gold standard, probably no longer is. Rapid flu tests for many years have been the most widespread available tests. They're fast, minutes from sample to result. They're very simple. Some of them are CLIA waived, require no equipment. However, rapid flu tests sort of suck. Despite occasional publications to the contrary, the sensitivity of the best rapid flu tests runs in the 50 to 70% range, and may run lower than that in adults who tend to shed fewer flu viruses. This figure is a convenient sample of the recent literature right before the 2009 outbreak, and selected by Medline search and what I could fit on a single page. And the key here is that the sensitivity of these rapid tests relative to either culture or some molecular method varies from a low of 47.7% to a high of 85%. The specificities generally are quite good. The comparator assay is important. Molecular comparators are really the gold standard. Culture a little bit less so. But none of the rapid tests are very sensitive. The problem is that in many places, for a long time, it wasn't rapid flu versus culture or rapid flu versus a molecular test. It was rapid flu versus nothing, because anything else was quite complex. And there is some evidence to suggest that if the choice is between a rapid antigen test and nothing at all, that the rapid antigen test does have some positive impact on care. An uncontrolled study in the VA hospital system looked at the use of rapid antigen tests in older adults, and the positive predictive value of fever plus a cough increased from 32% to 92% with a positive rapid flu. 20 out of 22 patients with a positive rapid flu and symptoms received antiviral therapy, compared with only 8% of patients with a negative rapid flu. This is not a controlled trial. It's really a descriptive study. But this is at least soft evidence to suggest that if the choice is between rapid flu and nothing, that a rapid flu test does have a role. However, rapid flu tests really do not perform well. This is a seminal study from Christine Ginocchio's lab on Long Island during the 2009 influenza pandemic, showing that in their hands, the Binax Now flu A and B test was only 9.6 sensitive versus either culture or PCR. The 3M Rapid A plus B was 40% sensitive, but neither performed at all well against the 2009 pandemic strain. If you're going to use a rapid flu test, you should make sure to educate providers on specimen collection. These tests require a lot of material to be positive, and a good specimen is absolutely essential. Test only during the flu season, because remember, calling false positives is a disaster in flu testing. And if you do testing when there is no flu in your population, all your positives will be false ones. Test early in illness, because flu is shed in the largest amounts then, and you can intervene then. And make sure that your providers understand the results. Make sure that they understand that this is an insensitive test and cannot rule out influenza. There's some interesting literature on the use of rapids by or in travelers to rule out to rule in influenza and decrease antibiotic usage and usage of anti-malarial drugs. All that's fairly soft and not really highly relevant to laboratory practice in the U.S. So make sure that if you do a rapid flu in your laboratory, or if you oversee the use of a rapid flu, that you put a comment with the result, that you remind providers that these tests are insensitive, that out-of-season false positives outnumber true positives, and that there may be known sources of error. Some of these flu samples have a problem with bloody samples. It's also highly desirable to provide supplementary testing for at least selected patients, your more compromised patients, and for off-season or early-season positives, which may be false positives. So have the ability to provide a molecular test for patients in whom making the diagnosis of influenza is essential, or in whom false positive results are possible. So I have another poll here. What are you doing for flu testing now? Send that one out. So here are the results of that. I think fewer people are doing nothing. More people are doing molecular tests, but still a very large fraction of the population of the laboratory attendees out there are still using rapid antigen tests. And I think that's appropriate. That's what we kind of thought was happening. But be aware of the limitations of those rapid tests and try to mitigate them by good communication with your providers. And I think the rapid antigen tests are or should be on their way out, because there are now molecular tests that are becoming as simple as rapid antigen tests. Not quite there yet, but getting there. Molecular tests for influenza can give results in an hour or so with real-time PCR methods. As a class, they exceed culture insensitivity, not because culture is not good, but because viruses fall apart and die in transport, but their nucleic acid remains. The detection properties of molecular tests do vary from system to system. They have moderately to very expensive equipment associated with them, so there is a bit of a barrier there to implementation. There are, as far as I know, no CLIA-waived molecular tests yet, but some of them are moderate complexity and certainly not at all complex to run. Molecular tests now are clearly the gold standard in flu testing. For the next few slides, my information sources are a listing of molecular assays from the CDC, the College of American Pathologists website for some pricing information, and manufacturer's website and PubMed for pictures, workflow, and other information. So here are the FDA-approved molecular influenza tests as of about a week ago. The Alere I Flu A and B, the Cepheid Xpert Flu, the eSensor Respiratory Viral Panel, the Filmarray Respiratory Panel, the IBIS Plex ID Flu, which seems to be off the market, so I've graded it out, the IQM Liat Influenza AB, the ProDesk ProFlu and ProFast, the Quidel Molecular Influenza A and B Assay, the QIAGEN Artis Influenza AB Rotor Gene Kit, the Simplexa Flu AB and RSV, and Flu A and B and RSV Direct, and Influenza A H1N1 sets of tests, the Verigene Respiratory Virus Nucleic Acid Test, and the XTAG Respiratory Viral Panel and RVP Fast. Of all of these, only 2 were FDA approved in 2009. So this is an area, again, that's really moving rapidly. And so stay tuned. Maybe they'll ask me back to talk in 2015. The first in alphabetical order is the Alere I Flu A and B. It's the most recently approved of the molecular flu tests. Moderately complex, 15 minutes to result. A little sort of toaster-sized instrument involved here. The workflow involves bringing the supplies up to room temperature, put the test base and the sample receiver onto the instrument and allow it to warm. Place a swab in the sample receiver and mix it in. Apply this little transfer cartridge to the sample receiver, move the transfer cartridge to the test base, close the lid, and let the test run for 10 minutes. And then the instrument will interpret flu A, flu B, or both detected or an invalid result. Cepheid's Xpert Flu assay detects flu A and B and then discriminates the 2009 H1N1 strain. It's approved for nasopharyngeal swabs, aspirates, and washes. Is moderately complex. The list price is about $50 per cartridge. The instruments for the Cepheid range from $25,000 to $175,000, depending on capacity, and it's about an hour sample to answer. The workflow is to take the sample from your viral transport media, put 300 microliters into the large hole, put the binding reagent into another hole, insert the cartridge, and start the assay. The eSensor Respiratory Viral Panel is one of the multiplex flu tests. It detects flu A, AH1, AH3, A2009, H1N1, and B. So it subtypes the flus quite extensively. Gives, in addition, RSV A and B, paraflu 1 through 3, human metapneumovirus, human rhinovirus, and adenovirus B, C, and E strains. This is a highly complex system. Lists for $90 a test. I couldn't find the price of the instrument, and it also requires a separate thermal cycler and separate extraction. So a fairly substantial equipment requirement for this complicated high throughput multiplex assay. So the workflow of this involves an offline extraction, reagent prep, thermal cycling PCR, digestion with an exonuclease, and then a detection step. Overall, 6 to 8 hours. The BioFire Filmarray Respiratory Panel is another one of the multiplex tests. Detects a whole swarm of human respiratory viruses, and in addition, 3 bacteria, Bordetella pertussis, Mycoplasma pneumoniae, and Chlamydophila pneumoniae. It's approved for MP swabs and is moderately complex. It's a pretty simple test to do. And the list price is $129 per sample, and the instruments run about $40,000 each, with a sample to answer time of about an hour. So for the Filmarray, you insert the pouch into the loading station, inject the hydration solution into one side and the sample into the other side of the instrument, add the pouch to the Filmarray, and start the run. The IQM Liat Influenza A/B assay is from IQM. IQM's recently been acquired by Roche, and Liat stands for lab in a tube. It's a little roller tube with reagents on it that, as the roller goes along, the reagents get squashed into various reaction chambers. It's a simple test for flu A and B, approved for NP swabs, moderately complex, and sample to answer about half an hour. And as you can see from the image here, it is definitely being marketed not at the laboratory market, but at the physician's office laboratory market. The workflow for the Liat is to add a sample, scan the barcode, insert the tube, and the results come out in about 20 minutes. The ProDes, ProFlu, and ProFast are real-time PCR methods from ProDes, which was acquired by Hologic. The ProDes ProFlu detects influenza A and B and RSV, and then the ProFast is able to discriminate H1, H2, and 2009 H1N1. And there are also some separate kits available for other respiratory viruses. Highly complex. The list price is about $45 for reagents. It requires extraction on a separate extraction system and then detection on the Cepheid Smart Cycler. And is about 4 hours sample to answer. The Quidel molecular flu A plus B assay is another highly complex assay for influenza A and B, approved for NP and nasal swabs. Requires a separate extractor and RT-PCR system, either the Cepheid Smart Cycler or the Applied Biosystems or the Life Technologies Quant Studio. And it's about 4 hours sample to answer. So again, another complex multi-step assay. The QIAGEN Artis rotor gene kit detects flu A and B. It's highly complex, approved for NP swabs. Requires a separate extraction with a QIAGEN system and then the RotaGene real-time PCR. The Simplexa platform has got several different flavors of influenza assays that run on it, all from Focus Diagnostics and 3M. The test detects flu A and B and RSV, and then a separate test discriminates 2009 H1N1. And this is highly complex, but there's also a direct version that's moderately complex and doesn't require a separate extraction. That's all runs on the platform with direct sample to answer. So it's about 4 hours for the conventional and about 2 hours for the flu direct. The Veregene respiratory virus nucleic acid test and RV Plus kit is from Nanosphere. Detects A, B, and RSV A and B. The Plus version also discriminates the flu strains. It's moderately complex, lists for about $70 for the reagents. I couldn't find a price on the instruments. And sample to answer is about 3.5 hours for the Veregene. So the workflow is to load the test cartridge and the consumables onto the processor. The processor processes the samples, and then the slide is taken from the processor onto the reader for resulting. Finally, there's the XTAG RVP and RVP Fast from Luminex. Detects a large number of respiratory viruses: flu, RSV, paraflu, metapneumo, rhino intravirus, and arbovirus, and all of those except for the paraflus on the RVP Fast. Highly complex, about 8 hours sample to answer for the RVP and about 6 hours for the RVP Plus. This uses a very elegant bead array technology to do this multiplex detection. So the workflow involves a multiplex PCR, and then for the conventional RVP, another enzymatic treatment, and then binding to the bead array and sorting and detection on the XMAP instrument. So there's all this confusing array of molecular tests, and I'm not sure how to help you sort out the confusion. There are numerous studies of these, usually a single test versus culture or 2 tests against one another. I picked one simple example just to show a comparison of the Veregene versus the Simplexa versus the author's homebrew PCR. This is a paper from the Jakelin Micron, January 2013. And in this study, at least, the Veregene was more sensitive for influenza A, B, and RSV. The Simplexa was not so sensitive against influenza B. I wouldn't take this as particularly as a definitive assessment of either system. Neither one of them performed as well as the author's homebrew test did. And the Simplexa test, at least I know, has been reformulated somewhat since this study was done. So there's a lot of literature on here, but very little of it compares multiple platforms. Just wanted to briefly mention the performance of the Alere versus PCR. The Alere's sensitivity for influenza A is about 88%. Specificity is very high, as you would hope. And at least in this small study, the sensitivity versus PCR for influenza B was 100%. One way to sort of look at these assays is to sort of look at complexity and speed and ability to multiplex. So what I've done here is I've graphed number of targets on the y-axis and time to result on the x-axis. The highly complex systems are in yellow. The moderately complex systems are in green. In general, there are some quite rapid and quite simple tests that tend to be single target or 2 target flu A and B. Alere, IQM, Xpert Flu, the Liat, the Simplexa Direct, that give results in 15 minutes to 2 hours. The Filmarray is kind of an outlier because it's a highly multiplexed simple test that gives results in roughly an hour. And then the there are other tests that are more multiplexed that tend to be in the 4 to 6 hour range and more complex. The thing is that throughput is kind of hard to figure out in some of these tests. The lower complexity tests like the Filmarray or the Alere or the IQ typically test just one sample per module. The throughput's then limited by the number of modules and the time per test. So for the Filmarray, it takes about an hour to run, and so that means you can run one sample per hour per instrument. Unfortunately, and this is a real issue in flu testing is low volume except during the season when the volume expands hugely. So figuring out the economics and the operational aspects of flu testing is a little complicated because it's very, very seasonal. The higher complexity tests may be harder to do, but they're often done in larger batches, in batches of 24 or more samples, depending on the number of targets and the capacity of the real-time instruments. So economies of scale can make higher complexity tests more efficient per sample if you do them in large volumes. Again, parsing cost is non-trivial for these. The cost per test depends on the reagent plus instrumentation plus labor costs. You have to figure out how many single test modules you need. You need to make sure to count in instrumentation for extraction if needed. Reimbursement for these is a moving target. It's not something I worry about a whole lot at the VA system, so ask an expert, not me. But if your bean counters are sophisticated people, which they unfortunately rarely are, the ability to diagnose influenza rapidly can move people through ERs faster, can save hospital admissions that are unnecessary. There's a lot of potential for savings elsewhere in the system with effective influenza diagnostics. So let's do another poll here. Do you plan to use a molecular test within the next year? I guess it's sort of a silly question. If you weren't at least thinking about it, you probably wouldn't be listening to this webinar. But silly questions are important to ask too sometimes. So you're pretty evenly divided. But it looks to me like about 60%, 55% are planning to use a molecular test within the next year. Note that that's quite a few more than are using them right now. And about 55% still are not ready to pull the trigger on molecular tests. One thing that can make flu testing on a molecular platform more economical is to have other tests on the platform. So I'm just going to push one more poll here. If you're using a molecular test already, do you have other tests on that platform? I'm interested to know what the answer is going to be there. So it looks like about 55% have got other tests on the platform, and about 30% are only doing respiratory testing on their molecular flu platform. So that's just other way to look at these, and one more complication to selling a molecular flu test to your institution. Does it make sense at all to test for the flu? I mean, the treatment for influenza is of modest impact. It's a disease with high incidence, but it's a disease with high incidence over a short period of time. When people are coming in with the flu, lots of people are coming in with the flu. This is a cost-effectiveness study out of the Annals of Emergency Medicine that assuming a $50,000 per quality adjusted life year willingness to pay threshold, which is basically the number that people tend to use. The most cost-effective treatment option is treatment according to provider judgment from 0 to 3% prevalence, treatment according to a PCR-based rapid test from 3 to 7% prevalence, and treating everybody at greater than 7% prevalence. The big hole in this analysis was that it ignored the fact that you may induce antiviral resistance if you treat everybody. Nonetheless, this is some evidence that at least maybe during the peak of the flu season, there's some cost-effectiveness justification for this testing. However you decide to test for flu, if you do, please instruct your providers on sample collection. It's probably the critical step in influenza testing. It's absolutely super important if you're using a rapid flu, which are very insensitive tests. But even with a molecular test, a bad sample means a bad result. So influenza virus infects ciliated respiratory epithelial cells. These are found in the nasopharynx. They're found down in the lungs. They are not found in the throat. A throat swab is a very, very bad specimen for influenza testing. Most people use a nasopharyngeal swab. You'll notice how far back this goes. It's almost to the front of the earlobe on the front of the patient's face. This is a fairly uncomfortable procedure, but I do it to myself every year teaching my medical students. It should burn a little bit to get these specimens properly and get the infected cells. Really train your providers well. Remember that false positives have potentially severe consequences, like non-treatment of a serious bacterial infection. Now, some places that are using highly specific molecular tests are testing year-round. Because remember, when it's summer here, it's flu season in the southern hemisphere. And influenza is transmitted year-round in the tropics. But you need to be careful about that. I think it's still legitimate and maybe prudent to primarily test during the flu season, October through December or March. If you have positives early in the season, very late in the season, retain that specimen for confirmatory testing. Another option is to monitor regional influenza per your state or CDC flu maps and only start testing when flu is reported in the area. And finally, remind providers to test early in illness. The tests are most sensitive early in illness, when the virus is shed the most, and the best therapeutic results are when the drugs are started early as well. So just to summarize, molecular tests are the emerging standard. There's a variety of platforms and formats that can fit many labs. There are variations between the molecular systems. Specimen collection, provider education, and testing only patients at risk is essential. And prevention still is better than diagnosis and treatment. So get your vaccine and wash your hands. So I have a song about the flu, and I'm going to turn control of the slides over to Darcy, but not control of the video, because I can't move slides and sing. And Darcy, I think you'll know when to move the slides. And all of you sitting there waiting to I'm not able to do that, according to somebody. Let's see. Well, okay, I'll just stop singing and move the slides then. But I urge all of you sitting there in your conference rooms to sing along. People will look at you funny, but that's all right. Next slide. This flu is your flu. This flu is my flu. I get it from you. I give it to you. So wash your hands and wear your PPE, 'cause this flu belongs to you and me. It says I can maybe move content control to Darcy. Let's see if I can do that. Sorry. We should have practiced this part. Try that. Okay. It's influenza, comes from your frienza, and we all dread it, so please don't spread it. If you get a fever, you'll be a believer. This flu belongs to you and me. This flu is your flu, this flu is my flu. I get it from you, I give it to you. So wash your hands and wear your PPE, 'cause this flu belongs to you and me. It's on the road now, it's spreading somehow, from nose to finger, those fomites linger. So wash your hands and cover up that sneeze. Achoo! Cover it up. This flu belongs to you and me. This flu is your flu, this flu is my flu. I get it from you, I give it to you. So wash your hands and wear your PPE, 'cause this flu belongs to you and me. So close the schools, the parks and playgrounds, reporters baying like a pack of bloodhounds. It's all around us, so get your flu vaccine. This flu belongs to you and me. This flu is your flu, this flu is my flu. I get it from you, I give it to you. So wash your hands and wear your PPE. This flu belongs to you and me. This flu belongs to you and me. Please don't give your flu to me. So I think it's time for questions now, right? Let's see here. So there were several questions regarding the flu vaccine. Can the live version of the vaccine give you the flu? If someone is, just tails off there. The live version of the vaccine can give you the flu only if that person is immunocompromised. Otherwise, it's a very safe vaccine. But you want to only get it if you're immunologically normal, and if there's no one in your household who could get the flu from the live vaccine. If someone is allergic to feathers or eggs, is there any risk to getting the egg-free version of the vaccine? Shouldn't be. That should not be a risk. What else might cause an allergic response to a flu shot in a patient who is not allergic to eggs, latex, or thimerosal? There's no thimerosal first in the flu vaccine. That's very important to know. I don't know what else there would be in there that could cause an allergy. People do have allergies to the most idiosyncratic things, but most reactions to the vaccine are due to egg allergies. Can you speak to the quality of the rapid flu tests, particularly the readers like Sophia and Veritor that claim they are correlated directly with PCR tests? The Sophia and the Veritor rapid tests have been compared to PCR. They are not as sensitive, and I don't think anybody claims that they are as sensitive as PCR. Their claim is that they are somewhat more sensitive than the older generation of rapid flu tests, but and are still quite sensitive, quite simple to do. I don't think they really approach the sensitivity of PCR-based tests, however. Do you have any thoughts on how long it takes to add these tests to our CLIA registration? I'm not sure exactly what that question means. Perhaps you could elaborate on that question a little bit. I mean, in terms of verification, flu testing is a pain in the ass to verify because they the analyte is only around for a short period of time. Your best bet is to work with a laboratory that's got some samples saved for you. Belinda, contact me offline for a copy of the song. Is it necessary to run other flu testing if the rapid testing is negative? It depends on what you want to do with the answer. If you have a patient who is at high risk for serious influenza, for whom you're likely to provide therapy, then it probably is necessary to run other flu testing if the rapid is negative. Some places use the rapid sort of as a rule in. If the person is positive, then you say they've got flu and manage them appropriately. If it's negative, then you look for some other cause. The problem is, of course, that sometimes the cause is still flu if the rapid is negative. So it really depends on the setting. A lot of facilities are saving the more expensive molecular flu test for inpatients or patients who are going to be admitted and compromised patients. And that's a reasonable kind of strategy. Do I have New York any hard data on a reduction in healthcare spending if a molecular test is used? I have not seen hard data. The best data I've seen is that cost effectiveness study from the Annals of Emergency Medicine. For most people, says Dr. Blaylock, boy, this thing is not behaving. Flu vaccines don't prevent the flu, but actually increase the odds of getting it. Mercury-containing vaccines is such an strong immune depressant that a flu shot suppresses immunity for several weeks. This makes people highly susceptible to catching the flu, he says. They may even think the vaccine gave them the flu, but that's not true. It depressed their immune system and then they caught the flu. That is basically bullshit. There is either no mercury or such a remarkably small amount of mercury in the flu vaccine. I believe all of them are non-mercury containing anymore. That there's no biological plausibility to that. People do often talk about, boy, I got the flu shot and then the next week I got the flu. Well, when do you get the flu shot? You get the flu shot at the beginning of the respiratory viral season. So people often come down coincidentally with a respiratory viral infection, often not the flu, shortly after getting the flu shot. There's no evidence that flu vaccines increase the risk of getting the flu. Please elaborate on the note regarding Alere negative, PCR positive on anything higher than 30 cycle thresholds. That's some data from the Alere poster. When the Alere was negative and the PCR positive, that was mostly in patients with shedding very small amounts of flu virus, greater than 30 cycles on the real-time PCR assay. Do you really need to get a flu shot if you never get the flu? Well, I don't know that you never get the flu. Do you never get a respiratory illness at all? I'm not entirely convinced by people who tell me they never get the flu. A lot of people don't have severe illness with the flu. A lot of healthy people don't get a real bad case of the flu, and they may just say they had a bad cold. But there is still value to getting the flu shot even if you don't get a severe case of the flu, because you decrease the chance of passing that flu on to somebody who is more vulnerable than you. And especially if you work in healthcare, I think it's really an ethical imperative to get the flu shot. I don't have any other questions that I can see here. Does anybody have anything else to say? It looks like we've got 30 seconds. I'd like to thank Alir for inviting me to speak, and I'd like to thank all of you for coming and attending.